Interesting few questions here. So the first question is antibioma. Antibioma. So what do you mean by the word antibioma? How it is going to form, we will see. Let us assume there is an abscess. There is an abscess, right? Now this abscess which is there, this is the abscess. The abscess which is formed, now what we are going to do, we are going to give treatment to the abscess. Suppose we give antibiotics. Right? Now what is going to happen to the abscess? The pus which is present in the abscess is going to get sterilized. So the pus which is actually present in this, the pus which is actually present in the abscess has now got sterilized as we have given antibiotics. Not only that, antibiotics are causing, they are causing what? They produce fibrosis. Due to this fibrosis, what happens? There will be the thickening of the abscess wall. Thickening of the abscess wall will occur. Now what happens? Which is the abscess? Now it has become something like this. Here it has become thickened. This is what I am going to call as what? Antibioma. Okay. Now did you get the point? First of all, there is an abscess. Abscess is something which is going to have pus. Now we have given antibiotics. What happens to the pus in the abscess? It has become sterilized. Now, due to the use of these antibiotics, what the antibiotics are causing is, they are going to cause the thickening of the wall of the abscess. Due to thickening, due to fibrosis, what happens? The wall of the abscess has got now thickened. Okay. And this thickened wall is going to appear as a hard lump, which I am going to call now as antibioma. Why I am calling it as antibioma? Because oma means what? Swelling. This swelling is formed due to the use of antibiotics. That is the reason why I am calling it as antibioma. Done? Now, what are all the various sites where we can see this antibioma? Okay, breast is one site where we can see. Thigh we can see, and even in the ischiorectal abscess, if for ischiorectal abscess, if we use antibiotics, then also there we can see ischiorectal fossa. Even there also we can see this. And one thing I want to tell about antibioma of breast is, it may mimic cancer breast sometimes. Okay. Now, this is a very small topic, antibioma. It is nothing but there is an abscess which consists of the pus. After giving antibiotics, the pus is going to get sterilized. Now, due to the use of antibiotics, there will be thickening of the wall of the abscess due to fibrosis. Ultimately, it is going to form a hard lump. This hard lump, which is formed due to the use of antibiotics, I am going to call it as an antibioma. What are all the common sites? Breast, thigh and ischiorectal fossa. In breast, this hard lump may mimic a cancer breast also sometimes. This is, you should know about antibioma. Right. Coming to the next topic. Next topic is pseudomembranous colitis or enterocolitis. What is this entity, pseudomembranous enterocolitis? First and foremost thing you should know about this is the causative agent. The causative agent is, you already know, it is Clostridium difficile. Clostridium difficile is the causative agent of pseudomembranous colitis. Now what it is doing is, you already know it is a toxin producing gram-positive bacilli. You already know this. So this Clostridium difficile is going to proliferate after antibiotic treatment. We have discussed antibioma, which occurs after the usage of antibiotics. Surprisingly, now we are discussing pseudomembranous enterocolitis. This is also occurring after the usage of antibiotics, very important. This Clostridium difficile is going to proliferate after antibiotic treatment. After antibiotic treatment, especially which antibiotics? Cephalosporins. Now, there is a normal gut. Let us assume that this is the normal gut, GIT. There will be presence of numerous bacteria over the gut wall, which are commensals of the gut, which are not doing any, which are not causing any disease to the human. But now what has happened was, now we have given antibiotics. These antibiotics are going to kill the normal gut flora. When we kill the normal gut flora, what happens is, this Clostridium difficile which is there, it is now proliferating in the gut wall. So due to the usage of antibiotics, the normal flora is going to get destroyed, and taking this as an advantage, now Clostridium difficile is going to proliferate that. Okay, especially after which antibiotic usage we are getting this? Cephalosporins. Now, what are all the clinical features with the page? Due to Clostridium difficile, a gastroenteritis like picture is going to occur, which consists of diarrhea, abdominal pain, and there may be fever also. So this is first, Clostridium difficile is not directly causing pseudoenterocolitis. First it will cause something, a picture like a gastroenteritis like picture it is going to cause. And this infection may progress to pseudomembranous enterocolitis. Okay. Now, how to diagnose a case of pseudomembranous enterocolitis? I have to get a endoscopy done. On endoscopy, what I am going to see is visualization of the bowel plaques, of inflammatory exudate, between the edematous mucosa. Okay, I am not drawing the exact one, but a similar one I will try to draw. Suppose this is the gut mucosa. What I can see here is, I can see visualization of the bowel plaques of inflammatory exudates between the edematous. I'm sorry, I cannot draw the exact thing. Something a similar picture I can see. Now, how to diagnose this condition? One thing, I can get an endoscopy done, but how to confirm the diagnosis? I have to get the detection of toxin in the stool sample. This is most important. By ELISA or something else, we can detect the toxin. Okay, that is the how we are going to make the diagnosis. How to treat this case? I can use metronidazole. I can use, very important, oral vancomycin, but still the drug of choice remains fidaxomicin. Once upon a time the drug of choice was vancomycin, but now recent trends the drug of choice is fidaxomicin. So even after all doing that, what should I do? In refractory cases, what should I do? It's always get better to get the bacterial flora back to the gut. Okay, how to get that? I can do a fecal transplantation. Why I am doing this fecal transplantation? To restore healthy microbiota. So if you look at the pseudomembranous enterocolitis, the first thing is the causative agent. It is Clostridium difficile, which is a toxin producing gram-positive bacilli. What is this causing? After usage of antibiotics, especially cephalosporins, the normal commensal cells are going to be destroyed. Now, taking that as an advantage, Clostridium difficile proliferates in the gut wall, leading to some of the clinical features are abdominal pain, diarrhea, fever. These are all the features. And in some cases, this may progress to pseudomembranous enterocolitis. On endoscopy, we can see the visualization of the plaques and we can see the edematous mucosa. How to confirm the diagnosis of this Clostridium difficile infection? We have to get the toxin detection from the stool sample. And how to treat this case? Metronidazole is helpful. Oral vancomycin most useful. Drug of choice being the fidaxomicin. In refractory cases, I have already told you fecal transplantation to restore the normal microbiota. Then this is all about pseudomembranous colitis. Now coming to the mixed parotid tumor. So what do you mean by this mixed parotid tumor? Please note it down. Mixed parotid tumor is nothing but pleomorphic adenoma. Please write it down. Mixed parotid tumor and pleomorphic adenoma, both of them are same things. Now, pleomorphic adenoma, this is the most common benign salivary gland tumor. Okay. Now we will do one thing. We will classify the tumors of the salivary gland into two. One is benign and the other is malignant. So what are all the benign tumors? Benign tumors are only two things. First one is pleomorphic adenoma, which is the most common benign tumor, and the other one is Warthin's tumor. Whereas under malignant there are many, but few things I want you to remember are mucoepidermoid cancer, adenoid cystic cancer, and ethnic cell cancer. Usually there are many malignant tumors of the parotid, but what is basically required at your level is only three. One is mucoepidermoid and the other is adenoid cystic cancer and ethnic cell cancer. These three are enough for your exams. Now, how this parotid pleomorphic adenoma, benign parotid tumor, pleomorphic adenoma is going to present. Even before that, we will look into the what are all the sites you are going to see this pleomorphic adenoma. Now, it is going to occur in the parotid gland, everybody knows. Even 80% of the cases of the pleomorphic adenoma are going to occur where? They are going to occur within the parotid. Only few of them are going to occur in the submandibular gland. And very few may occur in the hard palate also. Right? Now coming to how a pleomorphic adenoma is going to present to us. Now you already know it is going to present to us as a swelling in the which region? Parotid region. Now painless mass. Painless mass. Usually where? Usually in the parotid region. Okay. I have already told you it is a benign lesion. So it is a well-defined mass. And not only it is a well-defined mass, it is even a mobile mass. A well-defined mobile mass which is painless in the parotid region. Always think in terms of pleomorphic adenoma. It is going to gradually progressive over the years. Okay. Now if at all when the pleomorphic adenoma arise from the deep lobe, in parotid gland there is superficial lobe and the deep lobe, both of them are there. But when pleomorphic adenoma arises from the deep lobe, there can be paratonsillar bulge. Okay, there will be a bulge over the paratonsillar area. Now I have already told you pleomorphic adenoma is a benign one. Rarely sometimes there will, what are all the features of a malignant tumor in the parotid or pleomorphic adenoma being getting into malignant, which is very rare, but still if at all there is sudden increase in the size, I have to think in terms of a malignant one. If at all there is facial nerve involvement is there, then I have to think in terms of a malignancy. Now this malignant conversion is very rare in pleomorphic adenoma. Coming to histopathological aspects. Aspects of pleomorphic adenoma and Warthin's tumor are important for the exam. Now, when I look at grossly, this one which is there, our pleomorphic adenoma is going to be encapsulated. Okay, it is an encapsulated tumor. So on cut surface, how I am going to look at it? On cut surface, there is a grayish white area and there is a blue translucent area also. What is this gray area is going to tell me? This gray area is nothing but the myxoid one, whereas the blue translucent one is nothing but a cartilage like stroma is nothing but your blue translucent one. Now coming to the, what are all the microscopic features of a case of a pleomorphic adenoma? What I am going to see is, I can see epithelial components, I can see myoepithelial components, I can see stromal components, all of them I can see. As I am going to see epithelial, myoepithelial and stromal, means various things I can see. That too the cells being oval cells, plasmacytoid is there, or a rounded is there, or various types I'm going to see. That is why I'm calling it as a mixed parotid tumor. I can also call it as a pleo. Pleo means what? Various forms is there. Pleomorphic adenoma or a mixed parotid tumor. That is why I'm calling it as mixed. So what are all the investigations I can do? I can get a ultrasound done, or I can get a fine needle aspiration cytology done. Okay. Now coming to how to manage a case of pleomorphic adenoma. In many textbooks it has been given as a different, but the actual management is what we are going to learn. It is in previously some of the textbooks has mentioned enucleation. Enucleation is a completely wrong answer. Why enucleation is going to be a completely wrong answer, we will look into. Suppose this is our tumor. Suppose this is the capsule of the tumor. Now our tumor which is there is going to have a pseudopods, means it can even breach the capsule and it is going outward. If I am going to do enucleation, what happens? These pseudopods which are there, even after doing enucleation, they will grow. What happens? There will be tumor spillage, and there is always a chance of recurrence if I do enucleation. That is why, what is the treatment I have to do? I have to do surgical excision with a cuff of surrounding normal tissue. Please note it down. Not a simple enucleation. I have to remove the entire one. I have to excise the pleomorphic adenoma. Along with that, some part of the normal tissue also I have to remove. Okay. So what are all the things which we have seen in pleomorphic adenoma? Mixed parotid tumor is nothing but the pleomorphic adenoma. It is the most common benign salivary gland tumor. We are dividing the tumors into two types. One is benign and the other is malignant. Under benign, we are studying pleomorphic adenoma and Warthin's tumor. Under malignant, what we are studying? Mucoepidermoid tumor, adenoid cystic cancer, and ethnic cell cancer. So this pleomorphic adenoma is going to present as how? Usually it is seen in the parotid gland, sometimes may be seen in the submandibular gland or the hard palate. So it is going to present with a painless mass in the parotid region, which is a well defined mass as it is benign, and it is a mobile mass, very important. Okay, not only that, so there will be gradual progression over the years. When to say, chance of malignancy is very rare, but when to say that it can be malignant? If there is a sudden increase in size or if there is facial nerve involvement, we can tell. What are all the investigations? Routine investigations, ultrasound and FNAC, or the things I can get done. Coming to histopathology, on gross, what I can see? On gross examination, if I look at it, the cut surface is going to show me some grayish white areas and some bluish translucent areas. Grayish white areas I am going to call it as a myxoid areas, whereas blue translucent areas are nothing but a cartilage like stroma. Coming to microscopy, I can see the epithelial components, I can see the myoepithelial components, I can see the stromal components as well. That is why I am using the term mixed for this pleomorphic adenoma. Now, how to manage a case of pleomorphic adenoma? It is not enucleation. Why? Because there will be pseudopods which will be there, which are going to breach the capsule. So simple enucleation along with the capsule is not going to suffice. I have to excise the mass. Not only that, I have to remove the surrounding normal tissue. Some part also I have to remove, so that recurrence is going to be decreased. This is all about pleomorphic adenoma, right? Coming to the next one. The next question is abdominal aortic aneurysm. So what is this abdominal aortic aneurysm? This is most common large vessel aneurysm is our abdominal aortic aneurysm. Okay. Now, even 95% of the cases of the abdominal aortic aneurysm are going to be associated with atherosclerosis. Means what? To diagnose it as a case of abdominal aortic aneurysm, okay, there is already atherosclerosis in the patient. So most common risk factor for abdominal aortic aneurysm, if you ask me without any doubt, I would like to answer it as atherosclerosis. Now, even 95% of the cases even are going to occur infrarenally. For suppose this is your abdominal aorta, these are your renal branches, okay. Most of them are going to occur infrarenally, means they are not going to occur above, they are always going to occur below the division of the renal arteries. So let us take a aneurysm over here. So most of them are going to occur infrarenally, and there is always a atherosclerosis. There is always a atherosclerosis is always a predisposing condition for abdominal aortic aneurysm. Now, most of the cases of abdominal aortic aneurysm are going to be asymptomatic, okay. Unless they rupture, they are usually asymptomatic, and some of them are going to get rupture, okay. If you ask me, the risk of rupture is depending on what? It is directly proportional to the size of the aneurysm, or you can call diameter, or whatever you want you can call. I am writing here size of the aneurysm, okay. With increase in the size of the aneurysm, there is always a tendency for the risk of rupture. Now, I have already told you it is mostly a asymptomatic condition, so it is usually found incidental finding only. It is usually a incidental finding. On examination I can find sometimes, on a routine radiography I can find sometimes, or an incidental finding on a ultrasound I can get. Now, suppose I told you most of them are asymptomatic, but what if it is symptomatic? What are all the symptoms with which it is going to present? It is going to have backache, and it is going to have abdominal discomfort. These are the features with which it is going to present. Some vague features only, nothing much specific. Now, there will be swelling. Please take it down. It is a pulsatile swelling or an expansile swelling. Very important for the exam. It is an expansile swelling. Now, most of the patients are asymptomatic, I have already told you. Now the question comes whether to intervene or not in these patients is a big question. Now, when to intervene in these patients? When to intervene in this patient? I am not talking specifically about abdominal aortic aneurysm. I am talking about complete aortic aneurysm for that matter. I am drawing the entire aorta, ascending, descending, and abdominal aorta I am going to draw for you. Now, if the size, I mean there can be aneurysm over here, or there can be aneurysm over the descending aorta, or there can be aneurysm in the abdominal part of the aorta. Wherever it is, when to intervene depends on the site of the aneurysm, okay. Now, if it is more than 5.5 centimeters in the ascending aorta, I have to do intervention. If it is more than 6 centimeters in the descending aorta, I have to do intervention. If it is more than again 5.5 centimeters in the abdominal aorta, I have to intervene. Now, any other criteria if you ask me? If the increase in the size, I mean last year it was only 4 centimeter, now it has become 4.5 centimeter, means what? There is a noted increase in the size is also there. So if the increase in size is more than 0.5 centimeter per year in case of ascending, or if the increase in size is 1 centimeter per year, or if the size is 1 centimeter per year in this abdominal aorta case also, any of this is going to meet, then you have to do intervention. Okay, 5.5 centimeters in ascending, 6 centimeter in descending, 5.5 centimeter back in abdominal aortic aneurysm. Whereas the centimeters increase in a year, if you ask me, 0.5 in case of ascending, 1 centimeter in case of descending, whereas in case of abdominal aortic also it is 1 centimeter. If you feel this difficult to remember, forget all the things. Our question is only abdominal aortic aneurysm. At least try to remember this. No one, mostly they won't ask questions on the ascending and the descending. Abdominal aortic, if you remember, that is also it's fine, which is more than 5.5 centimeter size is there, or if there is an increase in more than 1 centimeter per over an year, then also you have to do intervention. Now one more thing is how to measure the size. That is also a different story. You have to measure the size on an ultrasound. You don't want to get a CT or something else. Just on an ultrasound you can measure the size of the aneurysm, okay, on ultrasound. This is all I am telling you for asymptomatic patient. The moment patient is symptomatic, irrespective of size, I have to do intervention. Only if the patient is asymptomatic, I have to look at the size. If it is coming to abdominal aortic, if it is more than 5.5 centimeters, I have to do intervention. Or if there is a noted increase in the size of 1 centimeter in a year, then also I have to do intervention. Only if and only if it is asymptomatic. The moment it is a symptomatic case, definitely I am going to intervene without any doubt. Okay. With all these things in mind, we are going to the what are all the interventions which we are going to do in a case of abdominal aortic aneurysm, right? What are all the investigations I have to do? All the routine investigations I have to get done. All the routine investigations I have to get done. Like a full blood count, I have to get it done. LFT, RFT, coagulation profile, all these things I have to get it done. Not only that, I have to get you already know we are anyhow going to get an ultrasound done. Even a CT scan I have to get it done. Why? Because CT scan, the morphology of aneurysm, is best assessed on a CT. That is why it's better to get a CT scan also done. Okay. Now, I am frequently telling you the size if it increases more than 5.5 or if it is increased over 1 centimeter over an year, then we have to intervene. But the question is, what is that intervention? There are two types. One is open aneurysmal repair, or I can do it endovascular aneurysm repair. Now, if you ask me, sir, you are telling me two entities, which one is better means it's still a debate. Both of them are almost providing the same results. Both of them, in both places, we are using a prosthesis. Okay. But the thing here is, in open, what we are doing is, we are opening it and we are doing the surgery. But whereas in case of endovascular, we are not directly opening, we are approaching through the femoral vessels. Through the femoral vessels we are approaching, and we are going to pass the process also through them, and we are going to place there. So both of them are equally good, and there is still a debate which one is better. There is still a debate which is going on. We need not know all those things. Write both the answers in the exam: open aneurysmal repair and endovascular aneurysm repair. And one more thing I want to mention is endovascular aneurysmal repair, EVAR. Okay, right. There is a complication which can occur in endovascular aneurysmal repair, that is endo leak. Endo leak can happen. That is why you have to follow up this patient with frequent ultrasounds, frequent CT scans. You have to get that. Okay, this is all about our aneurysm. Coming to the abdominal aortic aneurysm. This is the most common large vessel aneurysm. We have already discussed 95% cases are going to have associated atherosclerosis in them, and 95% of the cases are going to occur infrarenally. Most of the patients are going to be asymptomatic. If at all there are symptoms, there will be backache will be there. and abdominal discomfort will be there. So next, if the patient, so if at all, how we are going to find this means it is an incidental finding only. On examination or on an ultrasound or a radiograph we are going to get it done. Now what is the criteria or when to intervene, if you ask me, it is completely different for ascending or descending or abdominal. Now we are studying abdominal. 5.5 centimeter increase is there, or more than 1 centimeter increase in a year is there, then you have to do intervention. Or if it is a symptomatic case also, you have to do intervention. Now what is the intervention means? There are two types. One is open aneurysm repair and the other is endovascular aneurysm repair. Which is good means both of them are equally good, and in both of them we are going to place the prosthesis over there. Okay, now means what prosthesis means? Suppose, let me draw for you. Suppose this is the aneurysm is there, we are going to intervene, and we have to make the aneurysm repaired, and we are going to place our prosthesis where? We are going to place our prosthesis in this area. This is what we are going to do, right? There is a complication with endovascular aneurysm repair, that is endo leak can happen. This is all you should know about abdominal aortic aneurysm. Thank you.